I work with Pima County, which is a county of over 1 million people in southern Arizona. We have the longest contiguous border with Mexico of any county. We have 2 tribes, and we're a very mixed urban, semi-urban, as well as rural county. Tucson is my home. I went to medical school here. My husband's from here, and I wanted to work here again. I actually started my job May 1st. So the pandemic had been declared. I don't think any of us recognized where we would end up. For a while, Arizona was the worst in the world. We had the highest COVID rates. We had days when we were having 1,800 patients a day diagnosed. We obviously had similar findings to other areas throughout the US where our elderly population and our long-term care and assisted living were first hit. That way we had a fairly significant amount of mortality in May because of that situation. But then what we found is what we've seen in other counties is that there was disproportionate impact of the pandemic. Most of that was related to ethnic and racial minorities. You look at what your armamentarium is, and it's so limited. You have masks, you have social distancing, you have washing. Is there a therapeutic that's been proven that we can start using? And I think the recognition that monoclonals were available, and some of that recognition came to us from the state, was really critical. There was this offer we were told about that we could work with ASPR, and ASPR would be willing to come in and set up a clinical team with one of our clinical facilities, and that we could broker that relationship. And so we seized that moment. We have a large community-based hospital that was very responsive throughout the pandemic, and we called them up and said, hey, we have this amazing opportunity. We need to get a decision in 12 hours. And I said, and you have to have someplace near an emergency room where we can set up an IV infusion center. And really, I think it was 45 minutes later, they called me back and said, okay, when do you want to go? As the health department, we are not the gatekeeper to monoclonals, but we are definitely the gatekeeper for knowing who the individuals are that are testing positive. And we try to get to our cases within 24 hours. We quickly put into the script we have for cases, we may have this therapeutic available to you if you meet these guidelines. If you say yes, then we will send you the appropriate information to refer you to that one facility. But we did have other facilities where you could also get monoclonal antibodies. The question we got a lot from the people that had COVID wasn't necessarily, do you recommend this? Because part of our script had, this is what we know about MAB, and as things change, we would change what that script was. But this is how you access it. You have to know where to go. Part of our script is to determine, do you need services? Do you have a ride? Do you need a ride? It's our responsibility to make sure that we've put this information in a palatable fashion that meets the needs of different people. We did a huge press release the day we started. We used our Pima County Medical Society. We did our own social media campaign. We were very clear that we did not require identification or funding for you to get access to monoclonal antibodies. Now, obviously, we want ID, we want to know who you are, but the underpinnings of that statement is that we have a large undocumented population. We wanted our undocumented population to feel welcome. We stood up a congregate care workforce within the health department. They had reached out to every long-term care, most of the assisted livings that were known to be licensed in the county. So we had an early access into those communities. We worked to get the ability to do monoclonals at the long-term care centers where we started to see outbreaks. And we've had significant amount of success in those settings. In one setting, we gave over 50 different therapeutic courses of monoclonal antibodies to people that were identified to have COVID with actually, I think, very, very limited mortality. I think that that's what many of us saw with monoclonals, this recognition that it works. We saw a cohort of people not die as therapeutics become available, as interventions become available, and you know from a scientific perspective they're effective, you want to grab and integrate them. The fact that we've been as transparent as we have been has alleviated some of the negative concerns. Have we had our share of protesters, of people that may or may not believe in vaccinations? Yes. But I think at this point, what we've done is say, we're in the community, we're of the community, we're for the community, and our goal is to have this community be healthy and not lose any more lives.